Bismillahirrahmanirrahim. Quote of the day is, if Allah helps you, no one can defeat you. This is the quote from Al Quran. My name is Dr. Aamna Khalid. I'm PGR Community Medicine, and I will be presenting the topic of poliomyelitis under the kind supervision of Professor Dr. Saira Afsar, who is Dean Institute of Public Health Lahore. This is the outline of today's presentation. We will go through the introduction of polio, its epidemiology, clinical features, diagnosis, treatment and prevention, complications, types of the polio vaccines, recent updates on polio, and then the practice of multiple choice questions. So, polio is a highly infectious viral disease that largely affects children under 5 years of age and is caused by polio virus. This virus is from the family picornavirus, and it has three serotypes: poliovirus 1, 2, and 3. The serotype 2 and 3 are eradicated globally. Poliovirus survives in environment and it's transmitted via fecal-oral route. So this virus is stable at pH of 3 and it can survive at minus 20 degrees centigrade for years, at 4 degrees centigrade for months, and at room temperature for 1 day to several weeks. It's inactivated by heat and other chemicals like formaldehyde and UV light and chlorination. So poliovirus is actually shed in feces and saliva. It's transmitted by the fecal-oral route or the respiratory one. It replicates in the oropharyngeal and lower GI tract mucosa and enters the cervical and mesenteric lymph nodes. A primary or minor viremia follows with spread of virus to the reticuloendothelial system. So the infection may be contained at this point, or the virus may further multiply and cause several days of secondary viremia, culminating in the development of symptoms and antibodies. In paralytic infections, poliovirus enters the central nervous system either via secondary viremia or retrograde migration through peripheral nerves. So it affects the central nervous system. Earliest changes are that there is degeneration of the nucleus body that's followed by nuclear changes, and then finally the neuronal death occurs. At the level of spinal cord, lesions are mostly in the anterior horns, causing flaccid paralysis, and in posterior horn and intermediate column, they may be also be involved. So humans are the only reservoir of this virus. Transmission, as said, is fecal-oral. Oral-oral is also possible, or droplet or contaminated food or water and close contact with the infected person. Communicability is 7 to 10 days before or after onset, and virus is present in stool from 3 to 6 weeks. These are the very major risk factors of the disease: that poor sanitation, low immunization coverage, and undernutrition leads to the disease. Now we come to the types of polio. The first classification is based on the clinical features: asymptomatic, abortive polio, non-paralytic polio, and paralytic polio. These are the four major types. And then paralytic polio is further divided into three categories. We will go through further. Asymptomatic polio is the major type that's most common, 72%. No symptoms occur in this type, and virus it's in the gut, and person still sheds virus, and it's an important source of spread. No paralysis or no CNS involvement is there. Public health significance of this type is that it's hard to detect, and a silent transmission in the community is occurring. Then second one is the abortive poliomyelitis. It's the minor illness. It accounts for the 24% of the disease. Its mild and non-specific symptoms include mild fever, sore throat, malaise, vomiting, diarrhea. It lasts from 1 to 3 days. Still, no neurological involvement is there, and it's often mistaken for common viral illness. Then we have non-paralytic polio that accounts for 1 to 5% of the disease, and its features includes those of the abortive polio, like minor illness, flu, a fever, and vomiting, etc. And then the clinical signs of viral meningitis as well. And these symptoms include fever, headache, neck stiffness, back pain, muscle spasm, photophobia. Still, no paralysis is there. Complete recovery after 10 days of symptoms occur, and a pathology is that the virus invades central nervous system but does not destroy motor neurons. Then comes the fourth category, paralytic polio, that accounts for less than 1% of the cases of polio. It's the most severe and clinically significant type, and it's characterized by acute flaccid paralysis, AFP, Its onset is rapid. Usually, it's asymmetric. Deep tendon reflexes are reduced. Sensory functions are intact. Paralytic polio is then further subdivided into three types. First one is the spinal polio, second will be bulbar, and third will be bulbospinal. So first of all, we will go through the spinal polio. Among the paralytic polio, spinal polio is the most common, and it accounts for the 79% of the paralytic polio. It affects anterior horn cells in the spinal cord, and it predominantly impacts legs more than the arms. Again, the paralysis is flaccid and asymmetric. Muscle atrophy develops early, reflexes are reduced, but sensations are intact. Complication is that the permanent limb deformity occurs. Bulbar polio accounts for the 2% of this type, and it affects cranial nerves mainly 9, 10, 11, and 12. And symptoms are difficulty in swallowing, nasal speech, facial paralysis, respiratory difficulty, risk of aspiration. It can be fatal because of the involvement of the respiratory muscles, and it's fatal without respiratory support. So it's basically a critical emergency type. Then we have bulbospinal polio. It's combination of the spinal and bulbar involvement. So it leads to both the limb paralysis and the respiratory muscle paralysis and autonomic dysfunction. Complications of polio includes respiratory failure, post-polio syndrome, lifelong musculoskeletal deformities, and social stigma, disability, poor quality of life. This post-polio syndrome is actually that it occurs in 25% of individuals decades after recovering from the acute infection. Its features include muscle weakness, extreme fatigue or paralysis due to failure of the oversized motor units created during recovery from paralytic disease. This is the cause. Then second classification of polio is based on the virus origin. The first one is wild polio virus, WPV. It's actually the naturally occurring virus, and only WPV1 remains now in the world. Then the second one is the vaccine-associated paralytic poliomyelitis, VAPP. It occurs rarely in OPV recipients or their contacts, and it's due to mutation of the vaccine virus in the gut. Its risk is around one case per 2.7 million OPV doses. Then the third category, the third type in this category is circulating vaccine-derived poliovirus. CVDPV. It occurs when OPV virus mutates or circulates in under-immunized communities or regains neurovirulence, and its most common strain is circulating vaccine-derived poliovirus 2, CVDPV2. Then the third category is means the classification of polio is on the base of a virus serotype. Polio is caused by three serotypes of wild polio virus. Polio virus type 1 is the most common, most virulent, and it causes almost all paralytic cases today. And it's responsible for the ongoing transmission in Pakistan and Afghanistan. Then we have polio virus type 2. It's declared eradicated in 2015, but CVD PV2 outbreaks continue due to mutations in OPV. Most common cause of vaccine-derived polio outbreaks is this second serotype. Then we have polio virus type 3. It's declared eradicated in 2019, and it rarely caused outbreaks and is less neurovirulent than the first serotype. So the diagnosis is based on the clinical suspicion. AFP surveillance. AFP was acute flaccid paralysis, and lab confirmation. First of all, we will go through the clinical suspicion. As discussed earlier, acute flaccid paralysis is the sudden onset, flaccid, asymmetric, no sensory loss, and reduced or absent reflexes. And the age group mostly affected is less than 15 years, or if any age group suspected by the clinician. Then the second category of the diagnosis is AFP surveillance. WHO recommends 4 steps of AFP surveillance. First one is the find and report children with AFP. Second is transport stool samples for analysis. Third is isolate poliovirus, and fourth one is map the virus. We will go through the detail. The first step is find and report children with AFP. Early detection of any child less than 15 years with AFP, regardless of the cause, and it should be reported within 24 hours to the surveillance system. Then we have to transport the stool samples for analysis. Two samples are taken 24 to 48 hours apart within 14 days of paralysis onset. The sample should be 8 to 10 grams each, and it should be maintained at the temperature of 4 to 8 degrees centigrade. Then we have to isolate the polio virus at the laboratory. It should be tested for a polio virus through viral culture. Then we have to identify the type of the virus, either it's wild polio virus or circulating vaccine-derived polio virus or any or the vaccine strain. And then further molecular testing like PCR intratypic differentiation ITD, this confirms the viral type and origin. Then further, where we have to determine whether the AFP case is due to polio or non-polio cause as well. Then finally, we map the virus. Once the virus is identified, genetic sequencing is used to map the virus. It means we have to determine its genetic lineage. We have to trace the transmission chain, identify if the virus is locally circulating or not, imported from this region or another country. Either it's a new emergent strain, and this is important because we have to recognize the high risk areas, detect silent transmission, and design targeted vaccine campaigns. Then we have the third category of laboratory test for the diagnosis of polio. We can go for stool viral isolation or PCR for polio virus and intratypic differentiation. This distinguishes wild polio virus from the vaccine strain and vaccine-derived polio virus. Then we have genome sequencing. And then on the fifth number, we have the throat or nasopharyngeal swab testing. It detects poliovirus shed early in the respiratory tract, and it's just a supportive test. So now we come to the treatment of polio. There is actually no cure for polio. Early supportive care and rehabilitation are crucial only to prevent complications and improve quality of life. Treatments for polio focus only on on limiting and alleviating the symptoms. Heat and physical therapy can be used to stimulate the muscles, and antispasmodic drugs are used to relax the affected muscles, and this can improve mobility but does not reverse permanent polio paralysis. Now we come to the global and national burden and eradication programs for polio. The global burden is that WPV type 2 was eradicated in 1999 and type 3 was eradicated in 2020. At present, this data is taken from 2022. The endemic polio virus type 1 remains in only two countries, Pakistan and Afghanistan, and it's still the same till 2025. This is the global initiative, Polio Global Eradication Initiative. Um, this is the update available on their website from 19th November 2025 that in this week, like the week before 19th November, no WPV1 case was reported from Pakistan, but total 30 cases were reported from the country, and three environmental samples were positive from Pakistan, including KPK, Sindh, and Gilgit-Baltistan. Then another country is Angola, where two CBDPV two cases were reported in this week, and in Namibia, one CBDPV type 2 positive environmental sample was there. World Polio Day celebrated on 24th of October. These are the cases of WPV cases in Pakistan, and you can see that in 2025, one case has been reported in Punjab, 9 from Sindh, 19 from KPK, 0 from Balochistan, 1 from GB, 0 from Azad Jammu and Kashmir, and total polio cases till now are 30. And in the previous year, these cases were 74. So in Punjab, the one case that was reported was from Mandi Bahauddin, and the other breakdown of the district is also shown from KPK and Sindh. These are the cases of CVD-PV2 polio, and these are none of the cases are reported from since 2022. This is just a overlook of the number of cases in Pakistan in previous years. That you can see that this graph has always been haphazard. Sometimes there was a rise of the cases of the polio, and sometimes there was the reduction of the cases. And then you can also see the introduction of different types of vaccines. We will also go through the detail the trivalent vaccine, then the monovalent vaccine was introduced in 2009, bivalent vaccine was introduced, and so on. And this graph shows the again the cases and in the environmental samples. The blue color shows the positive environmental samples of Pakistan. This data is till 2024, and red color shows the WPV1 positive cases. This is the Pakistan Polio Eradication Program, Pakistan Polio in Sadad program, and that's working under the umbrella of the Global Eradication Program. Under this program, they have divided the districts into four categories. The first district is the category of endemic or core reservoirs, there where the cases are always present in the 12 months. And these are 20 districts. Then there is outbreak. Uh, um, I think this outbreak categories means that the sample is positive in a previous 2 to 3 months or something like this. I will confirm it later. These are 66 districts, and risk reduction areas are 29 districts, and maintenance are 44 districts. This map shows that the that red dot shows that in polio typic differentiation laboratory, the blue color shows polio nucleotide sequencing laboratory, and the green dot shows polio environmental surveillance laboratory. And you can see that in Pakistan all the three laboratories are present, but in Afghanistan none of them are there. Under our eradication program of polio, we have National Emergency Action Plan for polio eradication, and it's updated almost every year. And the goal of this program is of this action plan is to stop all wild polio virus type 1 and vaccine-derived polio virus type 2 transmission in Pakistan. This is the roadmap. Starting from July 2024, they had the goal in the first 2 months to reset the program to the eradication level. Then in the the next 4 months, they had the plan to reverse the current virological trends. And then in the next 6 months, in 2025, they plan to interrupt circulation of virus in remaining pockets. So this is just an overview of National Task Force for Polio Eradication, that how all the ministries are working for it. Then we come to the prevention. Primary prevention includes goals for prevention of the infection. It includes routine immunization, supplementary immunization activities in addition to the routine immunization. Then safe water, sanitation and hygiene, breastfeeding to promote immunity, and health education. Then we have secondary prevention goals for early detection and control. It includes AFP surveillance, stool testing, and outbreak response. Then we have tertiary prevention to reduce the disability, supportive care and rehabilitation, physiotherapy, and psychosocial support comes under it. So polio vaccination. We have two types of polio vaccines, inactivated and oral polio. Inactivated polio vaccine was developed in 1952 by Jonas Salk. It contains three serotypes, is safe in immunocompromised and pregnancy. It's a kill vaccine. It has further two types, conventional and fractional. Oral polio vaccine is live attenuated. Initially it was trivalent, but now it's bivalent OPV. Bivalent covers the type 1 and 3 serotype, and monovalent it's specific for every serotype. And the new thing is novel OPV2. It's genetically stabilized and it's used for CVD-PV2 outbreaks. The adverse reactions of OPV are rare. VAPP, we will go through it. That may occur. Mild diarrhea is rare. IPV, in case of IPV, local pain and tenderness, otherwise systematic reactions are rare. The contraindications of polio vaccine are um, in case of OPV, immunodeficiency, HIV with severe immunosuppression, pregnancy, and severe acute illness. In case of IPV, anaphylaxis to previous dose or allergy to the included drugs like neomycin, streptomycin, polymyxin B. So this is VAPP, vaccine-associated paralytic polio. It's rare paralysis caused by the mutated live OPV virus. It occurs in the virus recipients or close contacts. The risk is only 1 in 2.4 million OPV doses, and it's seen more in immunodeficient individuals. It does not occur with IPV. So the schedule of polio and EPI schedule is OPV 0 at birth, OPV 1, 2, 3 are given at 6, 10, and 14 weeks respectively, and IPV is given at 14 weeks and then and at 9 months as well sometimes. The dose of IPV is 0.5 ml given intramuscular, and its site is in anterolateral thigh in less than 12 months and deltoid for more than 12 months children. Or OPV is given orally 2 drops, and the schedule is 0 dose at birth and 6, 10, and 12, 14 weeks as discussed earlier. The cold chain is that in case of IPV 2 to 8 degrees centigrade, it's not frozen, but and OPV 20 degrees centigrade uh, for the long term and 2 to 8 degrees centigrade in the field, and it's very heat sensitive. And vaccine vial monitors are used mainly for OPV. Efficacy of OPV is 95 to 100% after 3 doses, and in case of IPV, 99% after 3 doses. So this is vaccine vial monitoring. It's actually a sticker placed on on the vial, and it changes color with the change of the temperature. So it gives us clue about we should use the vaccine or not. So we come to the recent updates. This is the update on WHO website for wild polio virus that 15 new WPV1 cases are reported in 2025, and you can see that in 2025-28 cases were reported and 4 were from Afghanistan and 24 in Pakistan. And the sample test, you can see that 53 environmental samples were positive from Afghanistan and 390 from Pakistan. And the last detection from Pakistan was on 7th of August 2025. This is an article published on the mission of polio eradication in Pakistan, a review of challenges and future recommendations. They have highlighted some challenges, including political challenges, security worries for the polio employees, myths and misconceptions regarding the vaccines, poor cold chain management, and inadequate sanitation systems. So this was just actually a brief overview of polio, as there is a lot of literature available on this topic. So now we come to the practice of MCQs. The first question is, a 3-year-old child in a refugee camp develops fever followed by asymmetric paralysis. Several other children in the camp also report flu-like symptoms. What is the most likely mode of transmission for this outbreak? Option A, blood transfusion. Option B, airborne droplets, fecal-oral route, direct contact with saliva, or vector-borne transmission.
B. Fecal-oral
Yeah.
route.
Yes, option B is the right one, fecal-oral route. Question number 2, sorry. Question number 2, during environmental surveillance in Karachi, polio virus is detected in sewage samples. What does this indicate about polio transmission in the region? Option A, there is a high likelihood of symptomatic polio cases in the population. Option B, polio is no longer a public health threat in this area. Option C, asymptomatic carriers are contributing to the spread of the virus. Option D, surveillance systems are not functioning effectively. Option E, there is no need for vaccination campaigns in the region.
Charlie.
Yes, option A is the right one. But this is in the MCQ, otherwise there was no case or sample positive in Karachi. Question number three is a mother brings her infant for vaccination in an area with a high prevalence of polio. She is unsure about the difference between IPV and OPV. What is the main advantage of OPV in eradicating polio? Option A, it provides lifelong immunity after one dose. Option B, it's easier to administer and induces intestinal immunity. Option C, um, uh, uh, it has no risk of vaccine-associated paralytic polio. Option D, it can be administered to individuals of all ages. E, it provides immunity to other viral infections as well.
Charlie.
Option B, vaccine-associated paralytic polio is actually associated with OPV only, not IPV. Question number four is a 5 years old boy of KPK presented in the OPD with complaint of difficulty in speaking, breathing, and swallowing. Doctors suspect the polio after history and examination. What is this type of polio in this patient? Option A, asymptomatic; B, non-paralytic; C, spinal; D, bulbar; or E, spinobulbar.
D.
Yes, D, bulbar polio. Question number five. In 1988, the World Health Assembly passed a resolution to eradicate polio to achieve its permanent reduction to zero with no risk of reintroduction. In the same year, which one of the following program was launched by WHO at the global level? A question. Option number A, Global Polio Eradication Initiative (GPEI). Option B, EPI. C, National Emergency Action Plan (NEP). And option D, Global Action Plan. And E, Pulse Polio Immunization.
A.
Yes, option A, Global Polio Eradication Initiative. Question number six, a 30-year-old male who contracted polio in childhood presents with progressive muscle weakness and fatigue in his lower limbs. This condition is most likely due to option A, GBS; B, post-polio syndrome; C, chronic inflammatory demyelinating polyneuropathy; option D, amyotrophic lateral sclerosis; option E, peripheral neuropathy.
B.
Yes, option B is the right one. Question number seven. A mother brings her 6-month-old infant to the clinic for vaccination. She asked about the difference between IPV and OPV. Which of the following is true about OPV? Option A, it requires a booster dose every 6 months. Option B, it is associated with vaccine-derived poliovirus in rare cases. Option C, it is less effective than IPV in providing immunity. Option D, it can only be administered to children older than 2 years. And option E, it provides no protection against wild poliovirus. Option B is the correct one. It's vaccine-derived polio. Question number eight is a global health initiative aims to eradicate polio. Which of the following strategies is most crucial for achieving this goal? Option A, exclusive reliance on routine immunization, or targeted vaccination campaigns in endemic areas, or development of a new vaccine, or treatment of symptomatic cases, or building a hospital infrastructure.
B.
Yes, B is the right answer. Question number nine. A healthcare worker in Karachi reports a 1-year-old child with fever followed by placid paralysis. Lab test confirms wild polio. What is the primary reason for persistent polio cases in Pakistan? Option A, poor immunization coverage in urban areas. Option B, lack of healthcare infrastructure in rural areas. Option C, vaccine refusal due to misconceptions and distrust. Option D, inadequate cold chain for vaccine storage. And option E, absence of routine immunization programs.
A.
Option C, yes,
C.
immunization coverage is actually not poor. Option C is correct one. There are misconceptions and distrust. Question number 10. Due to a vaccination campaign, a team encounters resistance from a community that believes polio vaccines cause sterility. What approach is most likely to overcome such challenges? Option A, threatening legal action against vaccine refusals. Option B, conducting a door-to-door vaccination program without community consent. Option C, engaging religious and community leaders to advocate for vaccination. Option D, introducing mandatory vaccination cards for school admission. And option E, increasing financial incentives for vaccination teams.
C. C.
Yes, C is the right answer. We should engage the community as well. This is the answer key to these questions. This presentation will be uploaded on the YouTube channel of Institute of Public Health Lahore. Thank you so much.
An excellent
Thank you,
presentation.
Dr.
Thank you so much.
Who does the best presentation?
इसकी अच्छी टाइमियां लेकिन इसकी बहुत अच्छी थी मैंने सुनी ही नहीं सही चलो निकलो हाँ उसकी बॉडी